Well, if you're a nurse and you have an EKG, then you do need to know the treatment, right? So when you're gonna ask me those questions, that is okay, but just know that, think about it as a nurse. Would you need to know the treatment? Yes, right? You're not gonna prescribe it, but you need to know how we're gonna treat, right? So just make sure you are treating all those and connecting all those together, okay? Practice assessment B, I'll post the sign up Genius for it this weekend. I'm talking to Blankenship just to get his dates, so that way you guys have that ahead of time. That will be in week 6, okay? And then the remediation will be due week 7, okay? So I'll get those dates out for you guys. Review sessions have been posted, had okay amount of people, not too many. So I know a couple of you were the only ones or 2 people. So make sure you're trying to make use of those. I post them on Remind. So on Remind, I post them in the 2-week bundles. When I post them, you put them in your calendar. The students will tell me, oh, you didn't post your reviews. I post them on Remind. I don't have set dates because I want to try to support those that are clinical the same day. So I post them on Remind. And students are saying, well, I missed it, but I don't want to have set dates. So anyways, Professor Blankenship has set dates, and I posted those for you guys before, so you guys can go back and just make a note of that. Whatever's on Remind that maybe you want to make a note of, maybe put it on your notes on your phone or add it to your calendar, just so that way it doesn't just go into Remind and then you're doing multiple things. Copy and paste, put it somewhere so you're more organized. At least that's what I would do, just so that way you can refer back to it, so you can attend those review sessions. That's about it. Any questions? Okay. All right, so we're gonna finish up with cardiac. All right, so acute coronary syndrome. These are patients that end up needing some kind of heart cath, so we talked about this already. I think this is kind of where we stopped. More so we finished talking about angiograms, so we're just gonna review that and then start with CABG after this. So when someone has acute coronary syndrome, we have modifiable, non-modifiable risk factors, right? So those are things that can cause patients to have this plaque buildup, that can build up in their coronary arteries. Of course, those are modifiable when it comes to education and making sure that patients will try to work around that to make sure that they continue to have patency in their coronary arteries. Now, once someone has an actual blockage in the artery, right, they're gonna have possibly a STEMI or a non-STEMI, right? So what's the EKG differences between STEMI and non-STEMI? Okay, ST elevation for STEMI, good. What about non-STEMI? ST depression and or T-wave inversion. So ST depression or T-wave inversion. Can they have none of those for a non-STEMI? Have no EKG changes? They can, yes. What would be an indicating factor then that they're having some form of non-STEMI if there's no EKG changes? The troponin will be elevated. That is going to show that there's stress onto the heart, right? Now when there's stress on the heart, troponin will be elevated. That's our go-to biomarker. There's also CKMB and there's also myoglobin. Those are also good biomarkers that we can use. However, they're not going to stay elevated for long periods of time like troponin will be, but we can trend it. That's why we like troponin, because troponin is a little bit more active, right, for us. So troponin would be one of the most common biomarkers that we kind of trend over some period of time. All right. So once they end up having a non-STEMI, your intervention is going to be maybe a stress test, right? Maybe they're going to wait until the next day and see how the troponins trend. They're going to put them on a heparin drip and just monitor the patient, put them on a nitro drip, right, and monitor the patient for some time, right? They may give the patient a little bit of time as long as their symptoms and their pain is being monitored. At any point of time, if someone with a non-STEMI says, okay, it's 2 o'clock, my pain is 4 out of 10, now it's about 4 o'clock, and the patient says, you know what, my pain is 9 out of 10 right now, and they were technically diagnosed with a non-STEMI when they first came in, what would be the plan of action to do right now at 4 p.m. being 2 hours of a change of time from the last time they had a 4 out of 10 pain? Repeat a 12-week EKG, because that non-STEMI can absolutely turn into a STEMI. And And then at that point, that's when we need to activate the cath lab team. We need to go to the cath lab, we need to open up that coronary artery, because the difference between a non-STEMI and a STEMI is partial occlusion versus fully occluded, right? And someone who's fully occluded, there's gonna be a lot of distress to the heart, a lot of oxygen demand, right? Not enough supply, and that's going to cause a lot of different issues moving forward. So this is going to be the heart cath where they go in and put that stent. They can also do the angioplasty, right? So that was the balloon, right? So we don't have a slide on that, so just make sure you write that down. They can do an angioplasty or a stent placement, right? The plasty is just the balloon that gets inflated, squishes the plaque against the walls, deflates that balloon. So once your patient comes back from heart cath, what's your priority assessment? Look at circulation, right? You're looking at the distal pulses, right, of that leg that they access, or the arm that they access if they were radial, right? And then what else are we checking?
Bleeding.
Okay, bleeding, sensation, good. Thinking about sensation, pulses, bleeding, the actual site itself, if it's bleeding, is there a hematoma, is it soft, is it firm, right? So you're really kind of focusing on that site, moving down to the leg, the circulation, things like that, sensation and stuff. Right? Of course, you're also making sure they're on the vital sign machine, you're monitoring their EKG, monitoring their vital signs, and of course their airway as well. But speaking more so focused assessment would be that area, right? The site and the distal pulses. All right, so this is kind of a little bit what we just talked about. The priorities there, which has pain, we think we're good on that. Now, one thing that I did mention, or I did post like a little article from, that talks a little bit about dual platelet therapy, right? Dual platelet therapy. It's a great little article. I think it was American something. But it talks about taking aspirin, status quo stent, right? They have to take aspirin plus another antiplatelet drug. They don't just go home with aspirin, right? We need a little bit more. For the first year specifically, they're on dual therapy. That means they take 2 antiplatelets. Why is that the case? Why would they need aspirin plus Brilinta or aspirin plus Plavix for 1 year after stent placement?
To prevent the pins so don't get clogged or anything.
Exactly, so we don't clog that stent, exactly, good. So they need dual therapy antiplatelets. So that's why you're gonna see, they're gonna be discharged with aspirin plus this or aspirin plus Brilinta. So those are, you guys heard of those names before? Plavix, Brilinta, brand names, but those are your generic names, right? So that's really important, because now that they have a stent, they can clot off that stent, know what's the point of the stent, right? So those are things to think about. Another thing we didn't talk about last week, which I don't really emphasize too much, just because I personally have never seen it done, or maybe you guys have, in clinical or anything. Have any of you guys seen thrombolytic therapy given for a STEMI, TPA? Not very common do they go give TPA, right, for that. But if percutaneous coronary intervention, that's the same thing as a heart cath, by the way. Heart cath has like 4 names, I don't know why, right? Coronary angiography, heart cath, right? Percutaneous coronary intervention, right? All of those are names, technically the same thing. Okay. So those are, if a hospital does not have a facility, an actual cath lab, and the patient is in severe distress, that's when they can give TPA. Not very common that they do that, but that would be the only time. There are some hospitals that don't have a cath lab, you guys are aware of that, right? So there's a lot of Kaisers that don't have cath labs too. That's why they have to wait to take them to like a different Kaiser and stuff like that. Most community hospitals that I've seen and like the clinicals that you guys rotated usually do have a cath lab. But if they don't have a cath lab and the patient's coming in with a STEMI and they're very symptomatic, they have to give them something more than heparin, because heparin is not dissolving anything, right? So that's the only time they would give a thrombolytic. But I personally never seen it done before. But your textbook does talk about it, so just make sure you are understanding if that ever does come up, you can. Because I've had students say, I thought thrombolytics is just for strokes. Technically, yes, and we give a lot of time for stroke systemically, right through the IV. But for your textbook, it can be given. That's pretty much all there. So these are your meds. We've already kind of gone over your meds. These are recaps, right? Nitro, vasodilator, right? Morphine, we talked about that last week, how it's going to help with pain relief, but also decrease oxygen consumption. You want to look for respiratory depression and hypotension. A lot of patients can get nauseated as well. Beta blockers. Beta blockers is really helpful because it does reduce afterload. And when a patient has a myocardial infarction, we don't want more afterload. We don't want more resistance that the ventricles have to overcome, right? We don't want more pressure onto the heart. So beta blockers are really good when a patient has an MI. When they go home, they will be on a low dose of beta blockers, maybe medium dose, depending on how their blood pressure and heart rate is. They're not gonna put them on a high dose if their heart rate ranges in the, low 60s, because then it's really gonna drop, right? But beta blockers really do help patients, and it decreases the infarct size. So when we have patients, when I used to work on tele, and they would get discharge status post STEMI, there's a checklist. Are they on antiplatelet therapy? You'll check that off. Are they on beta blockers or an ACE inhibitor? You'll check which one off they're on. Are they on some kind of cholesterol medication, right? Have they received a nutrition diet? It was like a checklist to make sure that the discharge plan was all intact, but a lot of them would have to go home with a beta blocker. If they are contraindicated to go home with a beta blocker, the doctor has to document why. If they are contraindicated to go home with a statin, the doctor has to comment why. Because if the insurance sees that this wasn't done, then the patient comes back for a STEMI, it's technically a bad readmission on the hospital, if that makes sense. So that's how we keep track about discharge planning and making sure that patients are discharged with the correct medications to be more preventative so that the patient doesn't come back. Obviously, we can't make them take it, so when they go home, they might not take it, but at the end of the day, at least it was prescribed. Thrombolytics, so alteplase, like I mentioned, good option for hospitals without a PCI option. You never give it for a non-study. And then the dual platelet antiplatelet agent. So before you give aspirin or Coprodrol, which is Plavix, what are you going to look at before you give these medications in regards of your labs?
PTT, INR.
PTT and INR, you're gonna look more at it with like your heparin, your warfarin. Platelets. Yes, your platelets. You're gonna look at platelets. You can look at PT and INR if you're suspecting any specific bleeding issue, but more so antiplatelets, you're gonna look more specifically on your platelets. With heparin drips, of course, you're gonna look at PTT. With warfarin, you're gonna look a lot more on INR, right? So each one kind of has its own specific lab. We really look at them all, don't get me wrong. We look at H&H, we look at INR, PTT, platelets. You wanna look at them all because they can signify different things, but really, if you really technically wanna talk about it, it's mainly your platelets for these drugs. Any signs of bleeding you would not wanna give. Any signs of bleeding you wanna notify the physician, right? So heparin and enoxaparin, that's where you're kind of looking at a couple other things, right? But you're also looking at platelets for these as well, for anticoagulants. Anticoagulants, heparin and enoxaparin, you're really looking at PT, INR, PTT, CBC, H&H, thrombocytopenia signs, bleeding, bruising. Statins, right? So we're looking at their cholesterol levels. Cardiac diets, right? So make sure we're educating them about cardiac diets, knowing that we don't want them to strain, right? So stool softeners, and then a lot of times we may start some cardiac rehab, or they'll start having low impact activity for exercise, making sure they're still getting nutrition, but again, low salt and low cholesterol. So as a patient has an MI, these are just kind of cues and interventions. If if a patient has an MI, we know that there's damage to the myocardial muscle. That can affect the contractility of the heart, which can decrease cardiac output, decrease perfusion. And a lot of times, if the contractility is weak, the patient's gonna go into cardiogenic shock, where now the heart looks like it's in heart failure. Fluid will accumulate into the heart, right? Increase SVR, what does that mean? Systemic vascular resistance, good. Good, so what does that mean? What's happening? The force. Okay, so increased force, where would that force be coming from? The left ventricle, right? So increased force in the left ventricle, so increased SVR. So do you think there's a lot of fluid or a lot of blood that's being perfused against that left ventricle for someone that's in cardiogenic shock? Probably not. So if there's a lot of force from your left ventricle right here, here's some blood trying to get out to get to the aorta, right? And there's a lot of force here, how's this blood gonna get out? It's not. So where's that blood gonna back into? The lungs, given why they have crackles, all of that. Sluggish cap refill, why are they having sluggish cap refill?
Because it's not going.
Because it's not coming out, right? So understanding the patho and how it works, that SVR, that vascular resistance is right here, so it's not coming out, so it's backing up into the lungs. Since it's not coming out, it's causing decreased perfusion. Okay, so then the organs start to also fail down the line if it continues, right?
So why would the cardiogenic shock have increased pressure?
Cardiogenic shock, cause some kind of damage to the ventricles or maybe the myocardium when they had the MI, and now they have like, hypertrophy in the left ventricle, so something is happening to the actual ventricle or the atrium in the actual heart that's causing it to not function and add more pressure. Yeah. So no one just really goes into cardiogenic shock without really an underlying issue. That's a good point. They usually have some kind of lethal dysrhythmia that put them into heart failure, or they had just heart failure that is just significant, right? Or they had a severe MI that caused them to have severe heart failure, right? So there's something that happened, more acute, that leads to cardiogenic shock. Okay. Look for any murmurs, because they can have the regurgitation of the mitral valve. They can end up having aneurysms and ruptures, and then of course dysrhythmias. All right, next thing we're gonna talk about is CABG. So CABG is going to be like open heart surgery, right? Where they do a bypass graft, coronary artery bypass graft is a CABG. And this is pretty much going to be used for patients who are not able to restore vascularization or perfusion through doing an actual cath lab. So I'll give you guys an example. Say that a patient comes in to the ER and he's been having like chest pain and angina for the last 2 to 3 weeks. He doesn't have a good sedentary lifestyle, really. He's he's a smoker, maybe has had, stable angina off and on. And for the last 2 to 3 weeks, he's been complaining of angina. And then all of a sudden, he woke up in the morning and he said, my chest really hurts right now. And the wife said, I think it's best we go to the hospital. When they go to the hospital, right, you see that this patient has so many comorbidities, so many risk factors, and the patient has a STEMI, so they take him to cath lab. Right, when they get to cath lab, they access with fluoroscopy and contrast, access the coronary arteries, and they see that the patient has such a high amount of diseased arteries in the coronary arteries that there's no way that a stent or a balloon can open up those coronary arteries. A stent is not like magic and it works for everybody. If there are coronary arteries that are very diseased or very, very thick plaque that has built up over time, in a lot of cases would be more those cases that have had the pain and maybe didn't address it right away, they're gonna need an actual open heart surgery. So then what's gonna happen to that patient? That patient will come out of cath lab, and then we'll talk about in 7. That's usually where they'll be on like a pump to help support the heart until we can get them into open heart surgery. But we're not gonna talk about it right now, but they'll come out, from CABG, and at that point, from the cath lab, and we need to get ready to take them to a CABG. They have to sign a consent, we have to find a surgeon that's gonna do the surgery, and there's a lot of hospitals that don't do open heart surgery, so they have to wait, like at Roselle, they come back out to me in the ICU, for example, and then I would have to talk to the case manager, let them know that this patient needs a CABG, and she or he needs to reach out to Long Beach Memorial, figure out which surgeon is willing to take this case, and at that point, transfer him over, maybe in like a day or 2, maybe 3 days sometimes, right? So with that being said, during those 3 days, what's super important? What am I running on this patient? What medication?
Some kind of vendor.
Some kind of thinner.
Maybe I should make
So I'm running a heparin drip, right, systemically. Heparin drip, right, you're gonna be giving routine aspirin, right, but at the same time, they're about to go get open heart surgery. So you wanna run something that is reversible, right? So you don't give them warfarin at this point, you won't give them something that's gonna be, gonna be more, I guess, thinning for the blood and they cannot reverse it, right? So really, you're gonna mainly just give heparin, and sometimes even aspirin, they'll have you stop it, but some surgeons are okay with it, that's a certain surgeon, depending on the surgeon. But heparin can go because they can give the reversal agent for heparin, and heparin gets reversed pretty quickly. Okay, so that's the point. Now, once they are ready to go to surgery, that's what they need the surgery. So, what is a CABG? How it works, and it's going to be that pretty much they're gonna form grafts. They're gonna put grafts into the patient's heart so they can have a different pathway to perfuse blood. Sure here. So first to start off with, before I get to that, so patients that end up needing a CABG, they have to be on the cardiopulmonary bypass machine. In order for a surgeon to perform this procedure, they have to work on a non-beating heart, right? So with that being said, we need perfusion during that surgical time. So they will connect the patient into a cardiopulmonary bypass machine where it's pretty much taking the blood, oxygenating it, and putting it back into the body. It's pretty much working as the heart during the time of the procedure. Do you guys think this can cause a lot of complications? What are a couple complications that you can brainstorm about with just thinking about a patient being on this device?
You get the heart started back.
Okay, getting the heart started back up, or having any, like, dysrhythmias or something like that.
Work properly. Yeah, something
Okay.
happened to mechanically.
Mechanically, okay, so the actual device, good.
Infection.
Infection, good, and then I heard hypothermia. Good, yes, hypothermia is a big one too. Infection, hypothermia, anything else? Do you think everything that goes in from the blood maybe comes out? Do things get diluted, concentrated? If that's the case, then what can happen to your labs? Electrolyte imbalance, right, yeah, electrolyte imbalance. So I have a slide on that, so we'll go over some of those, but just to brainstorm. So what's happening during surgery now? They're gonna form grafts. They're gonna take grafts, and these grafts are pretty much like a different pathway that is sutured onto the heart to let the blood perfuse through. So that patient, they couldn't actually go in and put a stent here. They don't just say, all right, sorry, I can't put a stent, we're gonna call it a day, right? They're gonna try to do something else as long as the patient consents And as long as the patient is stable enough to go through this surgery. The problem is a lot of patients that surgeons are like, they're not gonna be able to actually sustain the surgery. Then what? They're looking for other surgeons, trying to transfer hospitals, and then, then you're having a different discussion, right? But here's the blockage. Your textbook talks about CABG in very, very great detail. I don't think all of you guys are gonna wanna work at a CVICU, so I just want you guys to understand the basics. So the two graphs that I want you to know are the two common graphs that's used, which is the internal mammary artery and saphenous vein. And those are the two common ones that you see used. There's other ones as well. There's like radial artery, there's ulnar, there's multiple. There's synthetic grafts, different types of synthetic grafts. But these two are actually in our bodies right now. So, for our internal mammary artery, one end is connected to our left subclavian artery. All of us right now. That's where one end is connected. The other end is connected to our chest wall. What they would do in the surgery is they would disconnect it from the chest wall and they would suture it distal to that blockage. Because the end that's going to our chest wall is not doing anything for our chest wall. They would undo it from the chest wall and then suture it distal to the blockage. So now the blood will go and go this way instead of going this way. This part is already dead. And this part being dead is already going to cause them some kind of deficit in their ejection fraction. They're not going to be like, okay, I have a graft now, my ejection fraction is back to 65, 70%. It's not going to be like that. This part here is already damaged, it's permanent. But let's still supply this side before the whole thing becomes dead, right? So this is going to be your graft. This is going to be your internal mammary artery graft. The other graft they use is the saphenous vein. Does anybody know where the saphenous vein is? In the lake, yes, it's in the lake. So they're gonna take it off the lake, two ends, right? Not one end goes this way, right? Take two ends out, right? You take the two ends out. You're gonna suture one distal to the blockage again. And the other one's gonna go on the ascending aorta, other end. You suture it there. Now we have two grafts to go around the blockages.
Question?
Yes?
Is there a reason why they don't just go right over the damaged area? Is it just easier to do it here, or is there, why do they come all the way up to the,
Oh, so you mean like why?
just like jumping over the problem? Why don't they just go there? Is there a reason why they go all the way up to the, you know?
Why is the bridge so
Well-
long? Because that's dead already on that.
This right here? Well, this is the aorta, if you look at this is the aorta.
I mean, it seems like a big jump. I just wonder if is there a
Yeah.
specific reason why they're doing it? Is it easier to operate like that? Or?
Could be, that's a very good question, we can look that up together, I don't really know the exact answer to that. What just from looking at it from my knowledge base, I would say, cause this is the aorta here, so in this case, the blockage is here, but it could just be the supply that's gonna go through that subclavian artery, just the amount of blood that's gonna be perfusing, and the ascending aorta could be, but I don't really know.
Just, it's probably not gonna get close to going bad. It's a much bigger, maybe that's whatever.
Could be, I think it's more so the blood supply that's coming from that left subclavian artery, and that ascending aorta is the supply that will support it. We can look it up together on break.
Okay.
But that's a really good question. Yeah, personally, I've never worked at an open heart surgery center, like LaSalle and St. Jude's are the two hospitals I've worked at, and didn't do open hearts. Actually, St. Jude's, I didn't work in the ICU there, but, I haven't really seen it, but at Saddleback, where I've taught clinical before, they do this a lot. So I've kind of asked a couple questions, but that's a really good question. But,
Sorry, I have a question. Okay, so for the end of it, for both of them, is it just going to wherever the blockage is? Or is it like always a specific part of the heart?
no, this part,
Like I know you said it goes distal to the blockage, but it will always be in this one area.
No, it depends where the blockage is.
Okay,
Yeah.
so the top part is always gonna be.
Yeah, it's the same, and that's why he was asking, why is it that specific area? Yeah. So like, why is it the ascending aorta and the left subclavian artery, right, that's your question?
Yeah, instead of just going right around the column.
Yeah. Yeah, but this part here can change, so if the blockage is here, it'll go distal to the blockage there. The blockage is here, it's distal to the blockage, because you're trying to form a different pathway of that, the blood to go through, pretty much. That's what the graft is for.
Maybe it's cause of those are the smaller arteries, so they
Yeah.
don't want, they don't wanna, they might be thinking that it might get blocked in the future too.
Absolutely, yeah, I think it's more of a perfusion reason, myself as well, but exactly why. But, yeah. Those are the graphs. Alright, I'll post that for you guys on Canvas, it's also in your textbook. So, pre-procedure, we understand that you need to have informed consent. Like I mentioned, aspirin and other anticoagulants should be off the 1 week prior. If they are waiting, this is if they're scheduled, right? If they are more acute, there are some surgeons that may allow heparin drip because we can reverse it. But the aspirin, usually they stop it. They can continue their potassium, their antidysrhythmics, those meds can continue. And then you wanna work on your therapeutic communication, right? You wanna make sure that patients feel comfortable, it's a big surgery, they're gonna have, open heart surgery, so we wanna make sure that the family is comfortable, things like that, with giving them like therapeutic communication. You never wanna say, everything's gonna be okay, you're gonna be perfectly fine, right? You wanna say like, you're safe here, you're under good care, please let us know if you have any concerns, right? And monitoring your vital signs, we're looking at your blood pressure, kind of more so reassure them that they're in a safe environment, more than you're gonna be just fine, right? Post-CABG, they're gonna be in ICU, a lot of times they're gonna come out of surgery intubated. When they come out of surgery intubated, you're gonna probably need to extubate them at a certain point in time, so it just depends on when they're ready to be extubated. And then hemodynamics is gonna be very important. So, that patient that just went into CABG, do you guys think that patient could be a candidate for a Swan-Ganz catheter? Maybe if that surgeon wants to place it into that patient during the surgery?
Sure.
Yes, right? Because maybe the doctor's like, well, I wanna monitor his cardiac output precisely for the next 3 days. I wanna monitor how his preload is for the next 3 days, right? I want to know the stroke volume. So while they're doing the surgery, as they're finishing, or maybe before they start, they might place that catheter in, so that way it's ready. So then the nurse who's gonna take over can set it all up, and now the doctor has numbers that can reflect how the heart is doing. Not just, how's the BP, how's the heart rate, how's the rhythm. More so, okay, cool, how's the BP, how's the heart rate, how's the rhythm, how's the cardiac output, how's the stroke volume, how's the preload, how's the afterload, and get even more numbers, get more data to see how the heart is doing, right? So it's absolutely a good candidate. Doesn't mean it happens to everybody, but this would be an example of a good patient that we can use that catheter for. What else do you think would be useful for this patient? What other hemodynamic systems?
I have a question. I saw a couple of, in the critical care now on there. They put the external chest tube with the CABG patient.
Correct.
That's normal, like for everyone?
Yeah, so they do put a chest tube in for all of CABG patients, and that is used to drain. Because they do the mediastinal, right, so they open up that area, because there's blood that can build up and more drainage post-surgery, they put a mediastinal chest tube. It's not looking for bubbling, tidling, all that, they just use it as a drainage system, right? Yeah, so chest tube, okay. What other hemodynamic monitoring do you think we should put in the patient? A-line, right, arterial line, let's know the blood pressure and that. you wanna look for hypotension, because that can cause issues to the grafts. And we don't want those grafts to be damaged. We need to take care of them like little babies, right? Post-op, making sure that there's no bleeding or anything like that to the grafts. EKGs, tested like I mentioned, because they're just more for drainage. Foley care, NG tube, Foley cath, they might be on a vent. You guys see how they get like a heart pillow, right? A lot of times they use that to splint when they're coughing because they're gonna have an incision, right? So they're gonna have a chest incision, a full-on incision where they did the open heart surgery. The chest, a lot of times, is where they've taken the mammary artery from, right? So they made an incision to take that out. Where else can they have an incision? In the leg. So incision care is gonna be important as well. Epicardial pacing, they will have pacing wires that are in the actual atrium and the ventricle, or just usually the ventricles. And these pacing wires are just there in case there's an emergency. Okay, so they'll have pacing wires in the patient. So now complications, you guys already mentioned really good complications. Many of you mentioned hypothermia, which is a complication that they can have with this procedure. Lungs, they can go with atelectasis, pneumonia, pulmonary edema, they can have fluid overload as a complication of CABG. I apologize. Heart, so they can end up having decreased cardiac output, right? So what are some complications triggered at the heart? Status post CABG, dysrhythmias. And what's the most common dysrhythmia they can go into? AFib. AFib is the most common dysrhythmia they can go into. What's our treatment for AFib with rapid ventricular rate? If your patient goes into AFib and you're just 140, it's just beating away, right? 140, 120, 130. You guys know AFib is not consistent, right? It's gonna jump into your numbers. What are you gonna treat with? What's the medication? Yeah, okay, so we can get amiodarone and beta blockers. Those are usually your go-tos. Amiodarone is an antidysrhythmic, right? Beta blocker is gonna heart rate control. You can't just say, okay, my patient is 140, well, they're in AFib, that's why. Your patient just got a CABG, you're having the heart run at 140, you need to rate control, that's your priority. They can be in AFib, because at the end of the day, people live with AFib, but they have to be rate controlled. You cannot have someone in AFib cruising at 140 for the next 5 hours, okay? Your cardiac output is gonna decrease effectively, right? So you need to do rate control. So when you think about AFib with rapid ventricular rate, that means it's not controlled. Don't critically think about that. If I ask you that question, what's your plan? Well, if I don't control the heart rate, my cardiac output is gonna decrease profoundly, and you're not gonna have perfusion to your organs, you're gonna go into organ failure. That's how your critical thinking should progress. So what is my priority? My priority is rate control. Many of you will think that your priority is not to prevent a clot, right? Which is true. But at the same time, what's your first priority for treatment for someone who has rapid ventricular rate more in the acute setting? What you're gonna do is control that rate and also ensure that the patient gets treated with anticoagulation moving forward so they don't get a clot, right? Cardiac tamponade, so they have fluid that can build up in their pericardial sac. Hypovolemia, left ventricular failure, so if you have left ventricular failure, they're gonna need to be on vasopressors, and that's usually how they can go into cardiogenic shock. This is a little recap on AFib. So this is AFib. Just that EKG readout should look familiar. Okay. So amiodarone, again, most common. Beta blockers, I don't think we mentioned calcium channel blockers you can use as well. Digoxin we use, but a lot of doctors are a little more like, okay, let's try beta blockers, let's try amiodarone first, and then they'll go for digoxin a lot of times. All right, and so that's AFib. When you guys are looking at AFib, and I think I talked to a couple of you guys about this on office hours, you want to march. Are these marching together? No. When you guys look at a rhythm, and you see that they're not marching, it is not sinus. Sinus will always march. Even SVT marches, okay? They march. The QRSs are always going to march because technically sinus rhythm, sinus tap, sinus brady, it's regular, right? This is an irregular rhythm. They will not march. You can always do that test and you're like, okay, it's not marching. So I know sinus rhythm, sinus brady, sinus tap is out of this picture, right? Then you're gonna look and you're gonna see, well, what's all of this? Right? That is not one profound P wave with the QRS and the T, right? This is not one profound P wave. These are fibrillation waves, right? Or they might be sawtooth. If they're sawtooth, what is that going to be? Flutter, right? So if you see this, or if these were replaced with sawtooth, kind of like the one on your test last week, right? Those are going to be flutter waves, okay? Electrolyte disturbances, so we mentioned that, especially potassium and mag, so important. So look for fatigue, muscle cramps, signs and symptoms of electrolyte imbalances, especially heart palpitations, numbness. And then one I don't think we mentioned earlier was neural deficits. One given, they're on this machine, blood is going through, it can clot. And if that clot goes through and goes to the brain, and we know that AFib's already in the mix somehow, possibly, they're high risk for CVAs, right, during this procedure and even after. And they're on a ventilator, they're under anesthesia, so you might not be able to do your neuro assessment. So when they wake up, you really gotta make sure we do a good neuro assessment to make sure that they didn't have a stroke during the procedure. Because they could stroke out and we don't know. Right, because they're under anesthesia for the procedure. Okay, any questions on cabbage? So cabbage, I want you guys to understand why it's done, the two graphs that we use, and like more pre-op, post-op, and complications. Okay. Your textbook will go very, very in-depth of cabbage. You do not need to go in that depth. I want you to just know the general understanding of the concept, application of safety, things a little bit more nurse-focused. Pacemakers. Patient goes into sinus bradycardia. Let's do priority treatment. Atropine. How many milligrams of atropine can we get? Up to 3, right? Up to 3. So if someone comes in, sinus brady, symptomatic, you're gonna give atropine. At that point that you give the first dose of atropine, what do you wanna make sure you have on standby that you might have to use shortly? Transcutaneous pacing, the pads, right? You need a transcutaneous pacing pad. You should already have those pads on your patient. You do not want to wait till you get to 3 milligrams of atropine and you're trying to figure out where your pads are and your heart rate is going right back down to the 20s. Okay, you need to get those pads on. Patient sinus bradycardia, heart rate's in the 20s and 30s, severely symptomatic, you're pushing atropine, you grab the crash cart, you put the pads on, you're giving the second atropine, you're giving the third atropine. Patient is still symptomatic, Brady, you're turning on your transcutaneous pacer and starting to pace that patient externally, okay?
So it's not the AED.
Yes, it's on the AED, yeah. The Zoll, you guys will probably see it called like the Zoll monitor. The AED, like the normal AED, like what we see like the airport or something, I don't think they have those. But the AED in the hospitals, yes, like the Zoll, yeah.
Do you want to like secret them or
Yeah, good question, yeah, so it can be very painful because they are already bradycardic and a lot of meds that we might get are gonna cause more bradycardia. Doctors are pretty not like hesitant to give anything in meds. And it's really torturous to watch a patient go through it. Have you seen it before?
Yeah.
Right? Yeah, it's very painful. If they're stable enough blood pressure wise, they may give them something small, but all the cases I have seen, no pain meds are given. but they make us wanna move faster. How are we gonna move faster? And the next thing is, epicardial is just for open heart surgery or certain surgeries, where they just put the leads in during surgery just to have in case. Transvenous, so they'll start here, and what they're gonna try to do is get that patient into the cath lab to get a transvenous pacer as soon as we possibly can. This is not permanent, this is not permanent, this is not permanent. They don't go from a transcutaneous pacer to like, okay, let's go put a permanent pacer in, or else everybody would have pacemakers, right? Because this patient just came into the ER, we need to figure out why are they having bradycardia. Maybe she overdosed on metoprolol, maybe they took too high of a dose, maybe they're on calcium channel blockers that's, too high for that patient, and now they're more brady, right? We need to figure out why they are brady first, before we can actually give them the pacemaker. So in that case, we can put them on a transvenous pacemaker, which is going to be where they go in through the femoral vein. Yes, they go venous, because it's transvenous. Transvenous, they go through the vein, yes, large vein, and they're gonna go ahead and go into the heart, and they're gonna put the leads in the heart. And it's gonna come out with a little device that you're gonna be pacing your patient through that.
Is it common to put people on EpiFix or like
Yes.
EpiFix?
So during this time that you have the transcutaneous pacer, they will put them on an epi or zocdoca. Once they get the transvenous, the doctor will say, okay, let's keep it on for about 3 to 5 days, and let's see how the patient does. Let's give them time to get that beta blocker out of their body or whatever the case may be. So maybe it's like day 4, they'll come in, right? They'll turn off the pacemaker for the transvenous, and then what do you think the doctor's looking at? The underlying heart rhythm, right? That's on the monitor, that now is naturally coming from the patient. And doctor may say, oh look, she's in the 60s. How are you feeling? Okay, let's keep it off for another couple hours, see how she's doing, see how she's feeling. And maybe the patient does not need a permanent pacemaker. But if they turn it off, and it's like day 3, day 4, day 5, and they keep turning it off, and she keeps dropping, and the patient, they keep it down for a little, keep it off for like maybe 5-10 minutes, and the patient's like, I'm not feeling good, that means that patient needs a permanent pacemaker, right? But the transvenous is kind of that bridge between transcutaneous and permanent. Let's just make sure they really do need a permanent one, or can we rule out the problem that's causing the bradycardia?
I just wondered how long you would see that reaction with your cancer. 10-15 minutes maybe?
Usually. I've had patients that because they've lived in bradycardia for a little while, sometimes they might not feel the symptoms right away, and they're laying in bed. So that's when you wanna actually get them up a little bit, have them sit on the side of the bed, and that's usually where they'll start feeling it more. So if they're laying in bed, they're still kind of used to it too.
Right.
So pacemakers, you'll see spikes, right? If you see a spike, you guys can all imagine how a pacemaker spike looks like, right? If you see a spike before the P wave, what kind of pacing is that? A pace. If you see a spike before QRS, ventricular pace. If you see a spike before each, it is atrioventricular pace. That means you have leads in the atrium and you have a lead in the ventricles. Or ventricle, 1 and 1. This is different, and pacemaker is different than a AICD, right? ICD, which is an implantable cardioverter defibrillator. That will just generate and deliver a shock if needed. That doesn't pace. So say that you have this patient and he keeps going into VFib, and this is the second time he went into VFib, and he got brought back. Well, they're not gonna try to wait a third time. They're gonna say, you know what, let's just put an ICD in this patient, because in case he goes into VFib at work, at least this will shock him, right? And then he can come to the hospital and they can get a workup done, right? So someone who keeps going into lethal dysrhythmias for some reason, a lot of times it could be due to a previous MI, right? then they can have this ICD, so it'll shock them.
Is that painful, or is it, are they like,
Yeah, it's painful. They'll feel it, yeah, and they'll know, and it'll record, there's a recording of it at the, like, the company that is running it for that patient. So they'll come to the hospital and they'll show you the strip. Complications with pacemakers. They probably went over a couple of these, failure to sense, capture, and pace, right? So those are the malfunctions that you're looking for with your rhythms, so make sure you know those. Complications of a pacemaker can be infection, hematoma, right, pneumothorax, lead displacement. So what do you guys think? Would the first one be a fact or not? Regular pacemaker functions. These are patient teaching. Fact. Report any signs of infection. Fact. Keep incision dry for 4 days after implantation or as ordered. Fact. Avoid lifting arm with the pacemaker above the shoulder. Fact. You want to keep it in a sling until approved by the cardiologist. Okay to resume boxing or bar fights? Fiction, right? All pacemakers are MRI safe? Fiction. Not all pacemakers are MRI safe. There are pacemakers that are MRI safe though. If they are MRI safe, if you need an MRI, it's a process. Cardiologist has to be informed, the pacemaker has to be turned off, the rep has to be there with you, the pacemaker needs to be turned back on. So it's not just, oh, MRI is ordered, we have a pacemaker that's safe, let's turn it off and let's go, right? What about if your patient goes on comfort measures and they have a pacemaker?
on what measures?
Some comfort measures. And we're trying to, they're slowly passing. Do you think they can fully pass if the patient has a pacemaker? No, you gotta turn it off. How do you turn off a pacemaker for that patient if you don't have a rep coming in or anything like that? It's a magnet. A specific kind of magnet that they have that's like a larger size. You put that magnet over the pacemaker and it will stop the pacemaker from working. You don't actually need the rep to come in for that kind of case. But usually the rep will come in to interrogate the pacer if we think there's any issues with the pacer, or the representative will come in if you have like an MRI. Avoid close proximity to high output electric generators. Stop. If it's very, very high output, would you want to try to avoid that? What about microwave ovens? Microwave ovens are okay. It's more so high output. Travel is restricted. Fiction, but what's important with travel?
When they are
So, yes, right. Monitor, educate the patient, something important, educate the patient to monitor pulse and tell the healthcare provider when it goes below the predetermined rate. When someone has a pacemaker in, it's set at a rate. So they should be able to take that, their actual heart rate, and it can go over because they have their own beats, right? But we don't want it going under, right? So if it's set at 60 and your patient's like taking their heart rate and you see that their heart rate is running in the 50s, they should notify the healthcare provider. Because the lowest it should be is 60.
Question. So is it, you can have a pacemaker but it's too fast, what you think? Or is it only if it's too slow?
If it's too slow. It
Never
doesn't,
the other way.
it doesn't slow down heart rate. That's a good question. Carry a pacemaker information, you'll have a part. That's a fact? That's a fact. I don't know how many people wear medical or ID devices.